Welcome to the Hospital Medicine Unplugged podcast. Today we're undertaking, I think, a really critical deep dive into one of the most frequent and potentially lethal electrolyte disturbances we face in the inpatient setting. Hyperkalemia. It's a condition that, demands not just a rapid response, but also a really detailed understanding of the kinetics of our treatments. Because, well, the difference between a successful intervention and a catastrophic arrhythmia can sometimes be measured in minutes.
It really is a high-stakes scenario, absolutely. Our mission today, I think, is to move beyond just the textbook summary and really synthesize the current evidence that guides these time-sensitive protocols.
Exactly.
From the initial assessment and the acute stabilization right through to the long-term management strategies that importantly allow us to continue vital life-saving therapies like RAAS inhibitors. We need to dissect the nuances of the data, especially where maybe guidelines might contradict our gut feeling sometimes. Precisely. And just to frame this discussion for our fellow physicians listening, let's establish the clinical scope right away. Hyperkalemia, traditionally defined as a serum potassium concentration greater than 5.0 millimoles per liter.
Right.
Now, a 5.1 millimoles per liter might warrant an inquiry, maybe a medication check. But it's not typically an immediate emergency.
But our concern escalates rapidly once we hit that 6.0 millimoles per liter mark or higher. That's generally classified as severe hyperkalemia. Or really anytime we see clinical signs or, crucially, electrocardiographic signs of toxicity.
Right.
The core issue, and why this is so, frankly, terrifying in the hospital setting, is that hyperkalemia is profoundly associated with significant morbidity and mortality. Primarily, it's due to that immediate risk of life-threatening cardiac arrhythmias and sudden cardiac death.
And we know exactly who our high-risk populations are because, well, we see them every single day on our lists. Patients with chronic kidney disease, heart failure, poorly controlled diabetes.
And critically, those receiving guideline-directed medical therapy that involves renin-angiotensin-aldosterone system inhibitors, or RAASi, or maybe potassium-sparing diuretics.
Yeah, it's often multifactorial, isn't it? It typically happens when a patient with that underlying risk, say CKD, then develops an acute kidney injury or maybe gets a new offending medication added on top.
Exactly. So to really excel at the acute management, we first have to quickly establish the foundational pathophysiology. I mean, potassium homeostasis is really an exercise in extremely tight control.
It really is.
We maintain this very high intracellular concentration, around 140 millimoles per liter, compared to that really narrow extracellular range, maybe around 4.0 millimoles per liter.
Right, that steep gradient.
That gradient is absolutely essential for the resting membrane potential, for nerve and muscle function. The system balances, renal excretion, dietary intake, and crucially, cellular uptake. And that's primarily mediated by the sodium-potassium ATPase pump.
And that pump, that's the target for so much of our acute therapy, isn't it?
Absolutely.
When these regulating systems fail, either because excretion is impaired or there's a sudden shift of potassium out of cells, the extracellular potassium concentration rises. And this leads directly to the mechanism of cardiac toxicity. The elevated extracellular potassium, it reduces the resting membrane potential of the cardiac myocytes, pushes it closer to the threshold potential.
Yeah, it makes it less negative.
Exactly. Yeah. Which makes the tissue less excitable initially, paradoxically increasing the risk of conduction abnormalities. And eventually that leads to the disastrous neuromuscular dysfunction and, the fatal arrhythmias we all dread.
So when we approach the bedside, we really have to think about the etiology using a structured framework, right? Focusing on the multifactorial nature of the problem. What's the most common root cause we see?
Well, overwhelmingly, it's impaired renal excretion.
Yeah.
This is often a direct consequence of acute kidney injury or, established chronic kidney disease. But even without severe failure, other factors can reduce the kidney's capacity for potassium secretion. Things like volume depletion, hypovolemia.
Which reduces the amount of distal sodium delivery to the collecting duct. Or conditions causing hyperaldosteronism like type 4 renal tubular acidosis.
And probably the single largest modifiable factor contributing to impaired excretion has got to be medication-induced hyperkalemia.
Oh, absolutely.
We have this whole list of medication classes that are common culprits. They either directly impair renal excretion or they cause these transcellular shifts. The obvious offenders, the ones we prescribe daily, are ACE inhibitors, angiotensin receptor blockers, aldosterone antagonists, and potassium-sparing diuretics. Basically, RAAS blockade in its various forms.
Yeah, those are the big ones. But the list does go deeper, and this is really where that detailed medication history pays off dividends. We absolutely have to remember NSAIDs.
Oh yeah, NSAIDs, often missed.
They contribute significantly through renal mechanisms, right? They impair prostaglandin synthesis, reduce renin release, and so they reduce aldosterone activity. Yeah. We also have to think about drugs that are sometimes overlooked, like heparin, which can cause hypaldosteronism.
And that potent combination of trimethoprim and sulfamethoxazole. The trimethoprim component acts a bit like amiloride, blocking those epithelial sodium channels in the distal tubule and impairing potassium secretion.
It's almost like adding a potassium-sparing diuretic without realizing it.
Exactly. Failing to take a thorough medication history is, I think, one of the biggest assessment pitfalls in the acute setting. Easily done when things are busy.
Agreed. So beyond impaired excretion, we also have to look at redistribution these transcellular shift causes, where potassium moves rapidly out of the cells and into the extracellular fluid.
Yeah.
That sodium-potassium ATPase pump is sensitive to hormonal changes and, importantly, pH.
Right. And this happens dramatically with metabolic acidosis. Hydrogen ions are buffered intracellularly, and in exchange, potassium ions move out.
Or think about profound insulin deficiency, like we see in diabetic ketoacidosis. Insulin is such a powerful stimulator of that sodium-potassium ATPase pump. Without it, potassium stays outside the cell, even if the total body potassium stores are actually low.
And then, of course, you have situations of significant tissue breakdown, massive release of intracellular potassium into the circulation. That includes severe rhabdomyolysis, rapid hemolysis, or major trauma.
Yeah.
And certain specific drugs, too, like beta blockers, which block adrenergic stimulation of the pump, or succinylcholine, the depolarizing neuromuscular blocker that's a crucial consideration during rapid sequence intubation, can cause a rapid efflux.
Okay, so before we even consider any aggressive acute management, we absolutely have to perform the critical first step in the entire process, excluding pseudohyperkalemia.
Ah, yes, the bane of the night float call.
Exactly. That classic 2 a.m. phone call the lab calls with a potassium of 7.0 millimoles per liter. And the first thing you have to ask is, was the sample hemolyzed? How long did it sit in the tube?
Precisely. Pseudohyperkalemia is that falsely elevated serum potassium level. It's due to in vitro release during or after the blood draw. It's basically a lab artifact. We see it with sample hemolysis, sometimes mechanical trauma during a difficult draw, or in patients with really profound elevations in platelet counts, thrombocytosis or marked leukocytosis, particularly in hematologic malignancies.
Yeah, like CLL.
Exactly. The release of potassium from those excessive cells during clotting in the tube can artificially spike the serum level.
And recognizing this possibility is just critical because it prevents unnecessary and potentially profoundly harmful acute treatment. I mean, if you give a non-hyperkalemic patient insulin and dextrose because of a spurious lab value,
you're guaranteeing severe hypoglycemia.
Exactly. So the immediate need is confirmation. A rapid redraw, stat, or even better, drawing an arterial blood gas or a venous blood gas sample for that rapid point-of-care potassium assessment.
Which takes us directly into the initial assessment phase.
Right.
Speed is paramount here, but precision can't be compromised. The critical first step, as you said, confirm the hyperkalemia. We need that repeat potassium measurement, ideally not from the same hemolyzed sample source, to verify the level and rule out pseudohyperkalemia.
But done concurrently, almost simultaneously, is the immediate acquisition of a 12-lead ECG. We just cannot wait for the confirmatory lab before getting the ECG if that initial reading is critically elevated, say above 6 or 6.5.
Absolutely not. Clinically, we have to admit patients are often deceptively asymptomatic, especially with chronic or maybe milder elevations.
Okay.
However, we must be vigilant for symptoms that can progress quickly. Things like nonspecific muscle weakness, sensory disturbances like paresthesias, which can tragically progress to life-threatening flaccid paralysis.
Now, we have to talk in detail about the ECG paradox, because this is where I think many clinicians can make a potentially fatal mistake by waiting for those classic findings we all learned.
Right, the textbook progression. Peaked T waves, those narrow, tall, symmetrical tents, typically occurring when potassium is maybe between 5.5 and 6.5 millimoles per liter. Then, as the level rises further, we see prolonged PR intervals followed by a widened QRS complex, usually somewhere between 7.0 and 8.0 millimoles per liter.
And then the really scary stuff.
Yeah, ultimately, the loss of P waves, the development of that sine wave pattern, which is just an ominous pre-arrest rhythm, ventricular fibrillation, and finally a systole E.
That's the perfect textbook curve, the classic teaching. But the crucial caveat, and this really must be drilled into everyone, is that up to half, maybe even more in some studies, of patients with potassium levels greater than 6.5 millimoles per liter may show no ECG abnormalities whatsoever.
None at all. The myocardium can be electrically silent right before it crashes.
Exactly. Therefore, we absolutely cannot rely solely on a benign-looking ECG to guide our decision to treat or not to treat when we're managing severe hyperkalemia. We have to treat the number, the clinical context, and the ECG findings collectively and aggressively when that potassium level is critically elevated.
That's such a necessary shift in mindset. A reassuring ECG does not mean a patient with a potassium greater than 6.5 is safe. It just means they haven't declared cardiac toxicity yet.
Exactly. So concurrently with these initial steps, confirming the potassium, getting the ECG, our diagnostic workup checklist needs to be meticulous. We need to immediately look for precipitating factors.
Right. Check renal function creatinine, BUN. Evaluate acid-base status, maybe with a pH via arterial or venous blood gas. Measure the glucose level, and complete that really thorough medication history we talked about, zeroing in on RAASi, NSAIDs, potassium-sparing diuretics, trimethoprim.
And given that immediate risk of arrhythmia, the American Heart Association recommendations are pretty unambiguous. Continuous electrocardiographic monitoring is required for all patients presenting with severe hyperkalemia or those who we deem to be at risk for rapid progression or life-threatening arrhythmias.
Absolutely. We have to maintain that monitoring standard until the potassium normalizes, and any ECG changes have completely resolved, and importantly, until the risk of rebound hyperkalemia has passed.
Okay, so now let's move into the core of this discussion, the evidence-based acute management strategies. The guiding principle, as always, is that management is strictly guided by the severity of the hyperkalemia, the presence of symptoms, and of course, the ECG findings.
And we structured the approach around those dynamic 3 pillars, right? Stabilization, shifting, and elimination. We have to address these rapidly, often initiating stabilization, while simultaneously preparing the shift agents.
Okay, Pillar A, cardiac membrane stabilization. This is, I think we agree, a non-negotiable intervention. If we see any ECG changes indicative of toxicity, PTs, PR prolongation, QRS widening, anything, or if the patient has severe hyperkalemia, typically defined as greater than 6.0, or maybe greater than 6.5 millimoles per liter, even without ECG changes yet.
Right, and the mechanism here is just essential to remember, particularly for trainees. Intravenous calcium, whether it's gluconate or chloride, it does not lower the serum potassium one bit.
Not at all.
Its entire purpose is to rapidly antagonize the effects of that high potassium on myocardial excitability. It does this by changing the threshold potential of the cardiac myocytes, making them less likely to fire spontaneously. It basically buys us time.
Crucial time. Maybe 30 to 60 minutes until those shift therapies start to kick in.
And this is where we need to address that bit of controversy you mentioned earlier. Some recent systematic reviews looking at outcomes data have shown maybe limited, clear clinical benefit in terms of overall arrhythmia prevention or mortality across all hyperkalemic patients treated with calcium.
Right, which might lead some to hesitate, thinking, does this really work?
Exactly. But the clinical insight here, I think, is that calcium is essentially a non-competitive antagonist. It's not used for the number on the lab report, it's used for the ECG. If cardiac toxicity is evident, stabilization with calcium must never be delayed, regardless of what some outcome data from mixed population trials might suggest. When the heart is unstable, you give calcium.
Couldn't agree more. When the heart's unstable, calcium is non-negotiable. So the typical recommendation is 10% calcium gluconate, 10 milliliters TDV, given over 2 to 5 minutes. Slow push.
But let's get into the clinical nuance here. Calcium chloride contains roughly 3 times the elemental calcium as the same volume of calcium gluconate.
Right, it's much more concentrated.
So if the patient has good central venous access, calcium chloride actually acts faster and is often preferred because you get a higher elemental calcium load delivered more quickly, offering perhaps more immediate stabilization.
Okay.
But if they only have peripheral access, we absolutely stick to calcium gluconate to minimize that significant risk of tissue necrosis if the IV extravasates. Chloride is very caustic.
Yeah, you don't want that complication.
And critically, remember, we must be prepared to repeat this dose if those initial ECG changes persist within, say, 5 to 10 minutes after the first administration. Don't just give one dose and assume you're done if the ECG still looks bad.
Good point. Okay, so once the heart is hopefully stabilized, we move quickly to pillar B intracellular shift. These are the temporizing measures, right? Intended to rapidly lower the serum potassium level by driving it back into the cells, activating that sodium-potassium AT pace pump we talked about.
Exactly. We're buying several hours, usually, until we can achieve definitive removal of potassium from the body.
And the gold standard here, probably the single most effective acute therapy we have for shifting potassium, is the combination of insulin with dextrose.
Definitely. The typical regimen, the one we all learn, is 10 units of regular insulin IV combined with 25 grams of dextrose, usually 1 amp of D50. This therapy is highly efficacious. It generally lowers serum potassium by, say, 0.7 to 1.2 millimoles per liter within about 60 minutes. That's usually enough time to stabilize the immediate clinical situation.
But we have to tailor this dosing right. So especially for our audience of practicing physicians, that standard 10 units, 25 grams kind of assumes the patient is normal glycemic or maybe slightly hyperglycemic. For patients who are not hyperglycemic, let's say their blood glucose is less than 250 milli-GDL, we absolutely must increase the dextrose dose, usually to 50 grams, so 2 amps of D50, to mitigate that risk of hypoglycemia.
Crucial point. And for our patients with renal dysfunction or frank end-stage renal disease, who have much slower insulin metabolism.
Yeah, the insulin hangs around longer.
Exactly. We must be even more cautious. Sometimes initiating with just 5 units of insulin instead of 10, or maybe using a constant infusion of D10W instead of bolus D50.
And we have to be hypervigilant about the major risk here, which is hypoglycemia. It necessitates extremely close glucose monitoring, typically finger sticks, every 30 to 60 minutes for several hours after administration. You can't just give it and walk away.
Absolutely critical follow-up. Now, as an adjunct to insulin dextrose, we often consider beta-2 agonists, primarily nebulized albuterol, usually at a pretty high dose, 10 to 20 milligrams.
Right, much higher than a standard asthma treatment goes.
Oh, yeah. It works by stimulating those beta-2 adrenergic receptors, which enhances the activity of the sodium-potassium AT pace pump, promoting that cellular shift of potassium.
Its efficacy, though, seems a bit less predictable than insulin. Maybe lowering potassium by 0.5 to 1.0 millimoles per liter?
That's generally true. It's often used concurrently with insulin dextrose, particularly in patients who don't have end-stage renal disease, for a potential additive effect. However, you have to be mindful of its risk profile.
Tachycardia.
Yeah, systemic absorption can lead to sinus tachycardia or potentially even precipitate ischemia, especially in patients who have underlying ischemic cardiac disease. So careful patient selection and close cardiac monitoring are absolutely key when you're using high-dose nebulized albuterol.
Okay. And the third temporizing measure, sodium bicarbonate. Where does that fit in now? Its role seems much narrower these days.
It really does. We generally reserve bicarbonate specifically for patients with documented severe concomitant non-anion gap metabolic acidosis.
Oh, right, like in some RTA cases.
Exactly. The theory is that correcting the acidemia forces hydrogen ions out of the cell, which then allows potassium to shift back in. However, its efficacy is really unproven in patients who are normovolemic and not acidotic.
And it adds a sodium load.
Precisely. It can significantly increase the sodium load, which is often undesirable in many of our cardiac or volume overloaded patients. So it really shouldn't be standard therapy otherwise, despite its historical, almost reflexive use in the past.
Okay, good clarification. So now we move to pillar C potassium elimination. We've stabilized the heart membrane with calcium. We've shifted the potassium temporarily into the cells with insulin and maybe albuterol, buying us time. But that clock is ticking, right? Because those shift agents will wear off.
They absolutely will. So we need definitive therapy that actually removes potassium from the body entirely.
What are our options there?
Well, for patients who still have preserved urine output and reasonably acceptable renal function, loop diuretics like furosemide can be a valuable elimination strategy.
How do they work for potassium?
They enhance urinary flow and, importantly, distal sodium delivery to the collecting ducts. This indirectly promotes urinary potassium excretion. However, this is really only useful in patients who are non-oliguric, maybe euvolemic or hypervolemic, and still have functioning kidneys. They're pretty ineffective in the face of profound acute kidney injury or end-stage renal disease.
Right, can't pee it out if you're not making urine. So for true, rapid, and definitive removal, especially when the kidneys aren't working,
Nothing beats hemodialysis.
The ultimate potassium remover.
It really is the most rapid and effective method. The indications for emergent hemodialysis are pretty stringent, though. Severe or refractory hyperkalemia, particularly when it's coupled with renal failure, life-threatening ECG changes that are not resolving despite calcium administration, or in cases of ongoing massive internal potassium loading.
Like tumor lysis syndrome.
Exactly. Tumor lysis syndrome or severe rhabdomyolysis. In those situations, dialysis is often needed because you can remove several millimoles per liter of potassium in just a matter of hours, which you just can't achieve with other methods when there's ongoing release.
Okay. And then we have the gastrointestinal potassium binders. These agents work by exchanging potassium for another casne, usually sodium or calcium, in the gut, effectively trapping the potassium and eliminating it via the feces.
Right. Historically, sodium polystyrene sulfonate, or SPS, commonly known by the brand name Kayexalate, was really widespread.
We used it all the time.
We did, but its evidence for efficacy, particularly in the acute setting, is actually quite limited. And more critically, there are serious and well-documented concerns regarding its potential for severe gastrointestinal toxicity, including that dreaded complication of colonic necrosis.
Especially when given with sorbitol, which we used to do routinely.
Exactly, or even without sorbitol, particularly in postoperative patients or those with ileus. The risk is real, even if infrequent.
So the conversation around binders has really changed radically with the advent of the newer agents. This is where the depth of knowledge for hospitalists really matters now.
Absolutely. We now have pataromer and sodium zirconium cyclosilicate, or SZC. These newer binders demonstrate, pretty convincingly, superior efficacy in lowering potassium and, crucially, significantly better safety profiles compared to SPS.
Okay, let's differentiate these two new agents because the choice might depend on the clinical scenario, right?
It does. Pataromer is a non-absorbed polymer that exchanges calcium for potassium. It has a relatively slower onset of action. We're talking hours to days for maximal effect. This makes it highly effective for chronic management and maintenance therapy.
Right, good for preventing recurrence and enabling long-term RAAs therapy.
Exactly, it's excellent for that. SEC, on the other hand, is a highly selective inorganic zirconium silicate compound. It preferentially binds potassium over other cations.
And its onset.
Because of its selective and rapid binding capacity, it demonstrates a much faster onset of action. Studies show it can significantly lower potassium within just a few hours, not days.
So potentially more useful in the acute or subacute setting.
Potentially, yes. While its primary approved role is still more focused on chronic control, its rapidity makes it increasingly useful in those non-emergent acute settings where the potassium is definitely elevated, maybe needs to come down faster than pataromer would allow, but the patient is hemodynamically stable and doesn't have urgent ECG changes requiring dialysis. Knowing the kinetics of these agents really allows us to tailor the definitive therapy to the level of urgency.
Okay, that's a very helpful distinction. So moving beyond the immediate crisis now, we have to address ongoing monitoring, chronic management, and the specific needs of some of our special populations. Preventing recurrence and managing the complications of treatment are just vital.
Agreed. The kidney disease. Improving Global Outcomes, or KDIGO 2024 guidelines, really stress the importance of individualized monitoring protocols. They have to be tailored strictly to the severity of the initial hyperkalemia and the patient's comorbidities. This isn't a one-size-fits-all protocol. It must be risk stratified.
So what does that look like practically?
Well, for patients who presented with moderate hyperkalemia, say 5.5 to 6.4 millimoles per liter, after you've made initial management changes or medication adjustments, it's generally reasonable to recheck their potassium within maybe 4 or 6 hours to ensure it's stable or trending down.
Okay.
But if you are dealing with severe hyperkalemia, greater than 6.5 millimoles per liter initially, the recheck must occur much sooner, typically within 1-2 hours after those acute shift interventions like insulin. We absolutely need to catch any failure of the intervention or the beginning of that rebound phase immediately.
And this heightened vigilance is mandatory because, as we said, we have to maintain continuous ECG monitoring until the serum potassium level normalizes and the ECG changes completely resolve.
Right. And we must remain vigilant for 2 major post-acute intervention risks. First, that rebound hyperkalemia, which occurs quite predictably as the effect of the temporizing shift measures the insulin, the albuterol wears off. This often peaks around 4 to 6 hours post-dose. And second, hypoglycemia, which is a major, very common, and potentially dangerous risk after insulin administration, especially, again, in patients with impaired renal function whose insulin metabolism is sluggish. Got to keep checking those sugars.
Absolutely. Now, the discussion of chronic management, it almost inevitably centers on RAASi therapy, doesn't it? As hospitalists, we are often pressured or maybe feel inclined to just stop these agents immediately upon admission for hyperkalemia.
It's often the first reflex, yeah.
But we really need to emphasize that the discontinuation or the chronic down titration of these RAAS inhibitors should generally be avoided unless it's absolutely necessary, meaning only if other measures like adding a binder fail.
Because these agents confer such profound, proven cardiovascular and renal benefits, particularly in our patients with heart failure, diabetic nephropathy, and proteinuric chronic kidney disease, we really should strive to maintain them at optimal doses whenever possible.
So the decision often comes down to balancing that life-saving medication continuation against the risk of recurrent hyperkalemia. We have to look at the data that supports that balancing act.
Exactly. Studies like the DIAMOND trial for patarimer and the ZS005 trial for SSE explicitly demonstrated that using these newer potassium binders allows us to maintain guideline-directed RAASi therapy even in high-risk patients, without accepting that high risk of recurrent severe hyperkalemia.
So the binders enable the RAASi.
Precisely. And that strategy, using a binder to keep the patient on their RAASi, results in better long-term cardiovascular and renal outcomes than simply stopping the beneficial RAASi agent.
That really is the modern imperative, isn't it? We use the newer binders to allow the continuation of the core evidence-based therapy.
Absolutely. Now, when considering long-term prevention, we also need to touch on dietary counseling, but with significant nuance, particularly in our chronic kidney disease population.
Right, not just avoid all bananas.
Exactly. There's actually less emphasis now on really strict potassium restriction, particularly from healthy plant sources like fruits and vegetables, which contain vital fiber and other nutrients. The focus should probably shift more towards reducing non-plant sources of potassium, things like high salt, processed foods, and especially those potassium-containing salt substitutes, which often contribute much higher loads with less nutritional benefit.
Good point. We also need to give special attention to certain patient populations that might modulate our approach because their underlying pathology kind of dictates the rhythm of the management.
Definitely. Chronic kidney disease and end-stage renal disease patients, almost by definition, have profoundly impaired renal excretion. For those folks with refractory hyperkalemia or ongoing risk factors, urgent dialysis is often the definitive answer, and the risk is always markedly higher if they're on dual RAAS inhibition. Their inability to excrete potassium just means those shift therapies are only very temporary band-aids.
Right. The potassium has nowhere to go.
Exactly. Similarly, tumor lysis syndrome and severe rhabdomyolysis pose unique and often catastrophic risks because they involve massive rapid cell lysis, leading to an overwhelming acute and severe potassium load. These are situations of ongoing internal potassium production.
So monitoring needs to be even more intense.
Absolutely. They require aggressive monitoring, with potassium rechecks potentially every 6, maybe even 4 hours initially during the highest risk period. This has to happen alongside concurrent aggressive treatment of the underlying cause, like hydration for rhabdo or resburicase for TLS. And often, it mandates early nephrology consultation and consideration for dialysis, because the rate of potassium release can simply outpace the capacity of our shift agents.
Makes sense. And finally, just to round this out, we must be keenly aware of the potential complications of our own treatments, as they can rapidly shift the patient from a hyperkalemia crisis to a new crisis.
Very true. Hypoglycemia from insulin is, by far, the most common iatrogenic risk we cause.
Easily done.
Yeah. Beta agonists, as we mentioned, can lead to problematic sinus tachycardia or precipitate ischemia. And while less common now with the shift away from SPS, we must still remember the serious gastrointestinal complications associated with traditional binders like kayexalate, that risk of necrosis.
And overcorrection is possible too, right?
Yes, absolutely. We must also be vigilant about the risk of overcorrection leading to hypokalemia, especially if loop diuretics are used very aggressively in someone who responds well, or perhaps if a dialysis run is prolonged or overly efficient. Monitoring needs to continue even after the potassium starts to fall.
Okay. This has been, I think, a really critical review of a dynamic and, frankly, dangerous condition that really defines so much of our daily practice in hospital medicine. We've tried to synthesize the current evidence across the rapid assessment, the acute intervention, and the chronic prevention strategies, really emphasizing those necessary clinical nuances.
Agreed. It's complex, but manageable with a structured approach.
So just to reiterate the key acute management takeaways, because these steps really need to be immediate and almost reflexive. Use intravenous calcium immediately for stabilization if there are any ECG changes or if you have severe hyperkalemia, prioritizing calcium chloride if you have central access for faster effect.
Right. Then use insulin and dextrose, often with nebulized albuterol as an adjunct, for that rapid intracellular shift. But be incredibly mindful of dose adjustments for CKD patients and for non-diabetic patients to prevent hypoglycemia and monitor glucose closely.
And then rely on the definitive removal strategies, hemodialysis for patients with renal failure, life-threatening changes, or ongoing massive cell lysis. Or, increasingly, consider the newer potassium binders, especially sodium zirconium cyclosilicate, perhaps for faster removal in the non-emergent acute setting, and both ETZC and Patarimer for sustained potassium removal and enabling chronic RAASi management.
And the entire framework, really, from KDI Go to AHA guidelines, emphasizes tailoring the intensity of our monitoring. Recheck potassium within 1-2 hours for the highest risk severe cases. We have to do that to prevent missing rebound hyperkalemia and to detect those treatment complications like hypoglycemia early.
Which brings us back, I think, to the final and perhaps most critical provocative thought in modern hospital medicine practice regarding hyperkalemia. In a world where RAAS inhibition confers such profound, life-saving cardioprotective and renoprotective benefits,
Huge benefits.
the physician's decision really must move beyond just fear of the potassium level. It needs to be a thoughtful process, balancing the continuation of that essential medication against the immediate and future risk of hyperkalemia.
And the evidence increasingly supports our ability to perform that balancing act. We must continue to follow the data that confirms using these newer potassium binders. Patarimer and sodium zirconium cyclosilicate allows us to maintain optimal, guideline-directed RAAS inhibitor therapy in our most vulnerable patients, those with CKD and heart failure.
Right. Rather than simply discontinuing vital agents that we know improve long-term outcomes, the goal should always be optimization and achieving that long-term benefit for the patient, not just a knee-jerk cessation of good therapy because of a number.
Well said. It's about finding that balance and using the tools we now have to achieve it safely.